Welcome to the third day of MILI's Convene Conference. My name is Pinar Karacamandic. I'm a professor in the finance department and a health economist and the academic director of the Medical Industry Leadership Institute here at the Carlson School of Management. Thank you so much for joining our event this morning. Stolen Breaths wrote my University of Minnesota School of Public Health colleague, Dr. Rachel Hardiman, Associate Professor of Division of Health Policy and Management at the University of Minnesota and the inaugural Blue Cross Endowed Professor in Health and Racial Equity. This was the title of her article published in New England Journal of Medicine in July 16, 2020, co-authored by Dr. Eduarda Medina and Dr. Ria Boyd. I want to read the beginning of this article that I recommend all of you to read. In Minnesota, where Black Americans account for 6% of the population with 14% of COVID-19 cases and 33% of COVID-19 deaths, George Floyd died at the hands of police. Police, I can't breathe. He was a Black man detained on suspicion of forgery, an alleged offense that was never litigated or even charged, but for which he received an extrajudicial death sentence. Please, I can't breathe. He was only 46 years old. Please, I can't breathe. And he was loved. Thank you, Rachel Hardiman and colleagues, for writing that piece. Yesterday, justice was served in Minnesota. We hugged our children tighter. There was some sense of relief and also tears for those who we cannot bring back. We hope that healing may begin for George Floyd's family and our communities, especially our communities of color. As the healthcare community, it is our responsibility to understand and address the root causes of health inequities. This means we need to intentionally identify and eliminate the structural factors that support racism. It came up during our executive spotlight session with Dr. Jane yesterday. We need to approach this as a civil rights-like movement and support each other in that hard-fought battle. Let's all embrace this moment and make it a central turning point in our national conversation of racism, justice, and equity. Let's take action and make that action matter. Convene Conference this year is centered on health equity, and we cannot achieve this without addressing racism and justice. We're honored to convene researchers and industry leaders here to advance this dialogue. During the last 2 days, our speakers highlighted gaps in mental health care, drivers of social determinants of health and health equity. Today, we'll continue this dialogue, focusing more on solutions. Before we start our day, we also want to acknowledge our sponsors who made this event possible. Our presenting sponsor, United Health Foundation, our gold sponsors, Buying Benefits, University of Minnesota Office of Academic Clinical Affairs and Medtronic, and our maroon sponsors, Frederickson and Byron, Stella Care, Blue Cross Blue Shield of Minnesota, and Mayo Clinic's Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery. Now it's my pleasure to introduce our keynote for today, Jennifer DeCubellis, CEO of Hennepin Healthcare. Welcome, Jennifer.
Thank you, Pinar.
Jennifer DeCubellis was named CEO in February 2020. She was the Hennepin County Deputy Administrator responsible for the Health and Human Services divisions of the county, where she was a leader in developing Hennepin Health, the nationally recognized partnership between the county and the healthcare system that integrates medical and behavioral care with social services for patients on Medicaid. DeCubellis has served as an assistant commissioner for the Minnesota Department of Human Services, an assistant county administrator, and area director for Hennepin County. She worked at the federal level as an innovation advisor for the Center for Medicare and Medicaid Innovation, where she created and tested system changes designed to improve quality and slow escalation of cost. She also led mental health authority services in Harris County, Texas. DeCubellis has an MA from the Illinois School of Professional Psychology and a BA from the University of Wisconsin-Madison. Please join me. Welcome, Jennifer DeCubellis.
Thank you, Pinar, and thank you everyone for the honor of being here today. I'm going to pop up my screen really quick. Bear with me, technology is not always my strong suit. There it is. So again, I want to say thank you. It is such an incredible honor to be here today because it's more important than ever that we talk about health equity. So I'm humbled to be here following on the heels of yesterday's verdict. As we talk about the hill we climb together, it's important that we acknowledge it's long, it's hard, but it's not unsurmountable. As any good climber will tell you, you take it in incremental gains, you pause to rest, reflect on where you've been, and recharge for the next advancement. And yesterday we did just that in Minnesota. In honoring the life of George Floyd, the lives of people of color, and challenging our own systems to think different, to perform different, to realize a community that benefits everyone. I want to pause and recognize that this is an important pivot point, that we have a really long journey ahead to realize equity as a nation, but we also have a huge chance to realize these momentous gains on that hill working together. And if you hear nothing else from me today, I want you to hear it's possible. It's within our reach, but it will take all of us being intentional, working together, taking the gains, pushing through the setbacks, but we can and we must make lasting change, in particular in healthcare. A little bit about me, and as Pinar mentioned, I've recently, in the past year, joined Hennepin Healthcare. And I have a passion for systems design, making sure that the very systems that we have work for the people we serve. And yesterday showed us how much work we have to do. I took over as CEO a year ago, and it was because I see the potential, the absolute imperative for healthcare, for human services, for public safety, and for community to work together to realize optimal health outcomes and stabilize healthcare funding. This slide tells a little bit about who we are if you're not familiar with Hennepin Healthcare. We are an incredible trauma center, top 1% in the nation for the lowest mortality rates in the nation. But if we just focus on trauma and being an incredible system to respond at people's hardest times, we miss the opportunity for health equity in Minnesota and across the nation. And it is to say, how do we all pivot in healthcare to invest in wellness, to remove barriers, to do better? And we have a trifecta here at Hennepin Healthcare. And that trifecta is we have incredible services. And we partner that with training our future workforce in healthcare with over 70 training programs, state-of-the-art simulation center. We train over 50% of Minnesota providers. And that's a huge opportunity to change the game in healthcare and to make sure we're realizing health outcomes. We also have the third largest research center. So making sure that we innovate, and you'll hear a little bit about today, my call for action for all of us to innovate and change how healthcare looks in Minnesota and beyond. And we have the opportunity through that innovation, the research, the following the data, and making sure that we at the end of the day are not following hashtags and strong moments, but we're truly changing how healthcare works and rising up the outcomes for everyone. But we know as a health system, we can't do this alone. Healthcare is a team sport. It takes health plans, it takes public health, county social services, community-based organizations, and most importantly, community. And that's at the heart of what we do. Our strategic priority right now is health equity. We believe, looking here at who we serve, 70% of our members, patients, are people in public programs. 60% are people of color. 20% prefer a language other than English. And you see how the barriers in front of people stack up very quickly. Our nation struggles with racism. And I want to say very, very emphatically, this is not a policing issue. It is foundational. It is a systemic issue of all systems, and healthcare is no exception. It's really easy to point blame. It's easy to point fingers at others. It's easy to say this isn't about me. It's not mine to solve. It's much harder, but so much more gratifying to roll up our sleeves and be the game changers. And that's my ask of everyone today. Minnesota, sadly, as you heard earlier this week, it's a top healthcare state. That's the good news. But as soon as you sort that by race, we move from being top 1, 2, and 3 in health outcomes to being 46th, 47th, 48th in any given indicator. And that is our call for action. We have enough money, it tells us. We have enough talent. We have enough intelligence. We have good systems. But the systems aren't working for a lot of people. And they're not working for the very people that they're often meant to serve. As you can see on this graphic, 93% of our patients interact with more than one public system, whether that is healthcare, human services, criminal justice, housing, and as soon as you start layering those systems on each other, you realize it's a full-time job just to maintain your supports, just to get through the day, to follow all the rules, to jump through the hoops, just to tread water. That's our reality. That's the health systems we've built. And we've made being well really hard. Our systems don't work together. And what I put up here is the ecosystem we need. We need to develop systems that provide those foundational supports and create healthcare for the future. We need to solve problems, create pathways for well-being, and sustainable change for those who we serve. It's getting to better outcomes, smarter spending, and a true vision for wellness. I'm going to share some examples of how I think we can do that across healthcare. We have incredible clinicians. Clinicians know how to do their clinical work that they've been trained on. Social workers know social services. Public health knows health education and outreach. The list goes on. What we're not always good about is talking across sectors and partnering. We're not always good about building a business case for why things need to change, bringing data, bringing case examples to the forefront and moving real systemic change. So how do we do that? We teach people how to build a business case for change. It helps to reduce politics, reduce bias, reduce naysayers. It builds the why is this important to all of us and how do we get a path forward? And I want to encourage everyone to hear that no matter what you do, what your role is, you can make a difference. If you're a leader, you can set expectations and empower change. If you're in IT, you can look at the technologies that remove barriers for people and make it easier to be well. If you're in data and analytics, you can make sure race, ethnicity, language is a part of every outcome report. So we move the line, not just for some, but for everyone. If you're in nutrition management, as people inside of our hospital walls are, you can talk about some great things that are coming to the forefront right now. We've got nutrition folks that are talking about comfort food, culturally, comfort food being brought in to help in the healing and the wellness process. What I want to encourage everyone to think is, what levers do you have to pull? How do you pull them? How do you get partners to the table? And how do you move the line forward? Because all of us doing that is going to be the game change that we need. This outlines a way to think through, and I'll give you some quick examples of what is the problem you're trying to solve? Who are your stakeholders that you need to get to the table? What are your pressure points? What does the data tell you? Defining what are feasible solutions that you can build. And I can't emphasize enough how important the sustainability, and I know you're going to hear a little bit later today from foundations and philanthropic investments. if we put projects and initiatives together that don't have a way to sustain themselves, we're going to lose those as soon as the funding goes away. So what we're always looking at as we build these business cases is to say, how do I keep the money at the table longer term? How do we change the system to make sure that any effort we commit to in healthcare to move the line is a commitment to keep it there when we're realizing improved outcomes? And then at the end, it is about bringing it to size and scale, changing the very policies, embedding it in organizations. Healthcare is a competitive market. I can't say enough how we can't compete right now. We need to share best practices, share learning, and figure out how to spread it so that healthcare realizes different outcomes across the board. Here are a couple of examples to just, again, give you the vision of what is possible and how we can do this together. We reduce costs and improve outcomes in looking at the business case. One example at the top here is an emergency room diversion. We took our top 200 individuals that were expensive, were getting high crisis visits, and we said, what is the root cause of that and how do we change that? One example on here is we found individuals coming in for dental pain, high levels into the emergency department. And if you think about how healthcare works today, you get a high cost visit, you get a referral to a dentist. For many, transportation is a barrier, access to dentistry is a barrier, and we're surprised when they show back up in our emergency department 3 days later. What we did is we identified the need and we brought in mobile dental chairs right into the emergency department to make it easy, to make it accessible, and to make sure that people could get the care. That drops the costs right away, and it resolves the situation for the individual versus putting a Band-Aid on the scenario. Another quick example is housing. We found people coming into the emergency department for wound management, for diabetes care, couldn't take care of their own wellness because of their circumstances. By going through and building a business case and taking that money and investing it in the very solutions that we knew would make a difference for individuals, what we found is we could take those savings, we had better outcomes for people, better lives. We could take those savings and invest them into the next solution that changed what people needed to see. This graphic here shows you how we create those ecosystems and how do we look at the root causes of what's bringing somebody into a constant crisis cycle and not getting to those wellness ideals. And how do you look across the areas to get to that sustainable change? I'd call out one example on here, which is in the maternal child health space. We knew that it was important to invest in moms. We know that Black mothers have incredibly different outcomes for themselves and their babies. And we knew we needed to get them into prenatal care. We needed to create a safe environment for that. But we also needed to make sure they could take care of themselves post-delivery. Right now, heading through the legislature is a part of those efforts are strategies to say, let's keep coverage in place for new moms so they can take care of themselves, take care of baby, and create that wellness path forward. I would give one more quick example on healthcare systems, addressing food insecurity. Hennepin Healthcare at one point was looking to address food insecurity. And one thing we could do is we could give a bag of food to somebody. It feels good in the moment. You could provide a referral to a food shelf. You helped a little bit longer term. But think about what happens as healthcare. We linked individuals to career pathways, to education, to employment, to building a future forward where they could change the root cause, the poverty, the racism, the barriers, and we could remove that. It's easy to say, but that's not my job in healthcare. And I would challenge us that wellness is everybody's job in healthcare. Here's a couple of quick other examples. Integrated access team. This was a proposal in the emergency. We were seeing high levels of emergency department and jail bookings for mental health and chemical health. One of the policy barriers are once somebody's in jail, connecting them to services, embedding the very services they need into the system becomes a policy barrier. You can't get paid for it. You can't get the funding to maintain the services and supports. And we said, let's not let those barriers stop us. Let's embed the very staff that need to be embedded into the jail services to connect people to mental health, to addiction, to longer term recovery to start their recovery and their treatment. And let's watch and see if we can reduce the amount of recidivism and that they're back in the jail because we took care of the health need that caused them to get there. It's a partnership. What we've done is we're now battling at the federal level to remove that policy barrier, to say we need to be able to fund services. And we actually need to step back even further and prevent that booking from happening to begin with. Here's another example of an employment program. Individuals in crisis. We were seeing individuals in psychiatric crisis, in addiction cycles. And what we found is that when we released them, put them back in the community, provided some supports, the cycles kept coming. And what we found is they needed job programs. We needed to change their home environment. We needed to change the circumstances that were causing the relapse to happen to begin with. And what we found was a lot of the very programs that they needed required them to be stable for a period of time. You can see on this graphic, when we said we're going to invest anyway, and we're going to prove and do a pilot to demonstrate what's possible, you can see the line that's on here are the costs in public programs, the amount of public programs wrapping supports around the individuals beforehand. And you'll see the number of programs they needed to support them afterwards. Creating pathways to wellness not only got incredible outcomes for the families, but it created generations of outcome of stopping trauma, stopping generational cycles. So I would end with just saying, we all have our roles. We all have our hills to climb to realize health equity. Don't stay in your lane. We need to work across disciplines, across sectors, across communities to deliver true health and to transform how we provide healthcare. It is a moral imperative, more so now than ever. I put up here a resource, Rebel Talent, and it speaks to why it pays to not just go with a system, but to be a disruptor of the system, to dream big, to envision better ways and to drive results forward. Nobody gets a pass right now. Health equity is everybody's business. It is now. We need to change the healthcare system. And together, I am absolutely confident we can overcome the hill. But each of us needs to commit to take the action we can and to share our learnings for spread and scale. We need to be the solution and put the care into healthcare. Thank you.
Jennifer, thank you so much for that empowering keynote. You have given so many examples and you've really so well represented that connective tissue that links our social care services, our medical services, our public health services to our communities all together. And thanks for leaving us with that message of be the solution, because we all need that kind of inspiration at this point more than ever. And thank you very much.